Yeah. This is a good day, a good week. And as you got here in a minute, Maxie was the first person to tell me we should go after these contracts, and he was right. And I'm dying to tell you guys all about it. One of my young guys is coming on. Is Dr. Oko on yet?
Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend this time with us, and we are looking forward to an exciting conversation and discussion with Dr. Ron Bailey. Without further ado, I will turn it over to Dr. Randall Maxey, our founder.
Thank you, Dr. Napier Stevens, Dr. Walks, and our favorite Maryland doctor, Dr. Hines. We have a special guest today. He's probably present more subjects and talks on the Black Health Trust over the past 4 years than any other person I can think of beside our co-moderators. And that is the fabulous Dr. Ron Bailey. Dr. Bailey is a past president of the National Medical Association. And I recall at a convention in Hawaii when, because of low sight, I had problems finding my spot, and Dr. Bailey led me to my spot in the line so we could have our walk in. I won't forget that. It was very important for me, Dr. Bailey, what you did. But let's introduce him, that he currently is the chair of psychiatry at LSU. The first Black chair, if I'm not mistaken. He graduated from the University of Texas in Galveston. He's been on the faculty and administration at a number of schools. I'll let him talk about that. But most importantly, he's one of the leading psychiatrists in the country, and we welcome him to our stage, Dr. Bailey.
Hello, thanks for having me, Dr. Maxey and team. Can you hear me, Dr. Maxey?
Yes, we can.
I'm sorry. Well, wonderful. Thank you so much for having me, Dr. Maxey, your entire group. Very fond of the quality work you've done now for 2 or 3 years, maybe close to 4 years with Black Health Trust. Very informative and helpful for, I think, all communities. So the communities, I think, of individuals who historically, in many regards, been underrepresented and underaddressed. As Ronald Maxey mentions, I'm very happy, like him, to be a past president of the National Medical Association. I am also very pleased to have been in these psychiatry chairman roles now for really right at about 16 years. First chairman was March of 2008 at Meharry, 7 years. Then I think January 15, I moved to Wake Forest as chairman for 4 years. Although not chairman, I think I functioned kind of like the vice chair, but CMO of the hospital, Kedron, in downtown Los Angeles, when I was assistant dean of education at UCLA Drew, working on their outstanding dean, Deborah Stitt. And I got this job about 3 years ago in early 21 at LSU. You're right. I was the first African-American to be chair, proud of that role. But very happy now that there are 3 African-American chairs of departments at LSU. Dr. Alfonson came from Arizona after a long career as a colorectal surgeon, as the chairman of surgery in September of 22. And Dr. Moulton, who was with me when I was at Vanderbilt, and Meharry came here as chairman of pediatrics in March of 23. So we try to stick together and work to help one another out and address issues that are relevant for all patients, but especially historically underrepresented patients in the Black community here in New Orleans.
Welcome, welcome.
Thanks.
The floor is yours, Doc.
Well, good. Well, today what I thought I'd speak about, I'm very excited about the fact that in December of 23, about 2 months ago, our department received a grant proposal for a comprehensive grant. We wrote actually in October of 21. So it's been 2 years working on this. We were denied twice. Granting season for us is always October. denied in October 21 and 22, and we got it in October 23, got the full notice in December for comprehensive healthcare services in the New Orleans jail. Basically, it's called OPP, or Orleans Parish Prison, or now newly they call it the OCJ, or the Orleans Criminal Justice Center. Absolutely, the first person to talk to me about this consideration was Randall Maxey. I unequivocally state that loud and clear. He and I discussed this activity at least 5 years ago or so when I was in Los Angeles. If it had come to full fruition, I want to give him a lot of credit. I've already mentioned this to the past presidents who met on Tuesday for a meeting in Philadelphia. A bit about the contract. So unfortunately, people go to jail or prison for a number of reasons. I'll begin by describing that, jails are different. Very often people are there who are pre-adjudicated. Some are arrested and even never charged. Some are charged and are not sentenced or convicted. Many, unfortunately, some poor communities are charged, settle, and take a plea bargain to be guilty, considered guilty to get out, who later argue they weren't really guilty at all. So it's a very different setting than what many Americans think of as prisons, where persons have been found guilty of criminal acts, going through the full legal process, and they're in a prison where you have to be there on a felony charge for more than a year, some of whom, more of those, of course, are being violent. Jails often are places where individuals with chronic mental illness are disproportionately housed. Many have heard over the last 10, if not 20 or 30 years, that the largest psychiatric hospital, if you will, or hospital-related services occur in the U.S. is the Los Angeles County Jail. That probably is true for every large city county jail in the country. New Orleans for Louisiana, Houston for Texas, Chicago for Illinois, because at the same time in the last, again, 2 or 3 decades, we pulled money out of the public mental health system. We poured more into the DOC or correctional system. And very often we have laws that criminalize behavior that we think as psychiatrists often cause of people who have psychiatric illness, chronic mental illness. As an example, I just happened, I've been here in Louisiana about 30 years ago on a job, and the largest state psychiatric hospital was about 25 miles north of downtown New Orleans, a place called Southeast Hospital in Mandeville. At one point, it had 350 beds as a state mental health hospital. Now that hospital does not exist. There's no place to replace it. There's an attempt to have monies for what they call wraparound services in New Orleans as well as the rest of the country. Often those monies dry pretty quickly. There's also less halfway houses for people who have chronic mental illness to be domiciled rather than otherwise. So as we have in New Orleans, similar to what you probably have in big cities in California and otherwise, there's a lot of people who are homeless. I think 60,000 every night in Los Angeles, for example, but much more commonly is due to chronic mental illness and a lack of a capacity to be able to kind of handle their own resolve than solely because they've all been engaged in overt criminal acts, let alone felonious acts, let alone violent acts toward others. So it really is an issue for psychiatrists. Randall Maxey told me years ago, as African psychiatrists should look at this very carefully and pursue these contracts. And he was right. I think the big number that I'll share, and I hope that your audience will talk to me about it, is although we're negotiating the contract again now, it was a 5-year contract that the last company had. The contract signed for 2019 to 2024 was $110 million over 5 years. So it's about $22 million a year, of which is comprehensive, so all medical services are included. The largest bite of that apple, Dr. Maxine, was mental health or psychiatry. So my piece as a chairman of psychiatry is $4.5 million. Just by example, for your audience, I have a $26 million budget, 78 full-time faculty in my department, 66 MDs and 12 PhDs. My largest contractual grant now is with our, what used to be called the charity hospital. Now it's called university. Charity washed out with Katrina and they had to get $1 billion to build a new hospital. So I have $7.5 million in my budget for 22 doctors every day in the university hospital. This $4.5 million at the jail will be my second largest contract. And by comparison, my third largest contract now will be the children's hospital. We have 40 beds there inpatient, 12 psychiatrists there every day, some inpatient, some outpatient, some CNAL, some emergency room. And that contract is about $3.5 million, just to give your audience an idea. So we should go from 26 million to about 30.5 million with this contract. We wrote the initial proposal, Dr. Maxey, with 84 FTEs, full-time equivalents, not just physicians, but all professionals, because that was a bit ambitious. We won't have 84. We're negotiating now. We'll probably be somewhere between a third to half that number. But I think it's going to take a full court press for us to be able to manage the number of MDs, psychologists, We have trainees, we want students, but we will have residents and fellows, just a plethora of associated staff, social workers, nurses, mental health techs, the people who sit with you when you're on one-to-one, things of that nature. My final comments are that the early numbers show that they're doing about 500 psychiatric new visits a month in the hospital, of which about 10 to 16 are the average number of suicide watch complaints every day, 30 days of the month. So it kind of gives you a bit of an idea of the bandwidth of what they need mental health to do, a bit of an idea of how much what the resources are in play. Clearly, we are open and looking for people who want to work in this setting here who are locally, and the others who may come from other places. And I'll end by saying I'm very excited that we have recruited our first forensic fellow to the fellowship, a guy by the name of Mohayed. Dr. Mohayed may be on your call today, Dr. Maxey. He currently is a chief resident of psychiatry there at UCLA Drew in Los Angeles, where you are. So let me start with that, a long introduction, but I'll end with where I started. I absolutely give a lot of this credit to Randall Maxey for talking about it and saying, Bailey, this is what Black psychiatrists should be considering, because so many African Americans with chronic mental illness are in these jails around the country. It's a good place to provide high quality care, humane care, and care that very often cannot meet the needs of people from our community in need. Let me start with that, Dr. Maxey. Thank you for the opportunity to get an introduction.
Now, I have a question. You mentioned the difference in jails and penitentiaries, but I sent you a copy of an article that Simon sent me. They found outside the jail or prison in Jackson, Mississippi, more than 250 bodies of prisoners. I'm presuming they were prisoners of unexplained deaths. And so jail and prison are a very difficult and dangerous place to be. How does this square with the way we treat prisoners and the psychiatric problems they have, and how they just can be buried without ceremony?
Well, tremendous point. I did receive the article and I read it. Tragic. I think Ben Crump, very prominent, what we call the new Johnny Cochran attorney, I think is on that case, and I think there's more to come. But there are three key issues that I think are very relevant before we even hear what the attorney determines in his workup. First and foremost, I used the word humane earlier. It's inhumane very often, the level of treatment, not just professional care, but just how we treat individuals once they've been identified as other than. You're a prisoner. We use terms like being a thug. We use terms like being a violent or at risk kind of individual. Disproportionate those terms are used against people who are African American, which I disagree with, but I think it happens. I think as well against people who have chronic mental illness. So that mistreatment happens to our patients, human beings who deserve fair and equitable care. I think is unfortunately a long part of our history in America. And I think this example can be one, as we find out the details, that might show that the same issue continues. The second issue is I think that our patients very often are vulnerable, at high risk, all too often due to mental illness and the ability or lack thereof to really think through solution-oriented activities to move toward providing safety and security for themselves and their families. They end up in circumstances that create high risk. Again, they're vulnerable, much more likely to be violent recipients of violent action and violent crime rather than perpetrators. The data has always shown our patients are more likely to be victims of violent crime than perpetrators of it. Like we had some work that I published early in my career that showed in some settings, you're as much as 35 times more likely to be a victim of violent gun violence, if you're homeless, non-domiciled, without a home, and have chronic mental illness, than if you simply are domiciled, have a home, like a halfway house, even with some forms of the more severest aspects of chronic mental illness, schizophrenia, schizoaffective disorder, and bipolar disorder, psychotic features being the three big ticket diagnoses. So the vulnerability of our patients comes into play when others have nefarious intent and are likely to engage in bad behavior. That could have happened here. Rarely will this type of thing happen. You may not find out about it. There may be bodies buried in settings that until media gets access to, we wouldn't really know. And the third and final point I'll mention, and I hope we can talk about a lot today, I think we have treatments for persons with brain illness that we just don't use enough and well. I'll circle back to my issue about the jail in New Orleans, but two things that I've been aware of for the 2 years that I've been here, that I've been speaking with a megaphone about on other media shows here in New Orleans, and I hope to implement these strategies when I get access June 1st, 24, to provide a provision of care. My doctor will provide the care for mental health in the jail here in New Orleans. Is one, when persons are opioid dependent, the best-in-class treatment around the world is what's called MAT, or medication-assisted treatment. Older medicine like methadone and the two newer medicines, Suboxone and naltrexone, are, state in class. None of those treatments, as we understand, were being given by the company with the contract earlier at Orleans Parish Jail. So individuals would actually come there, much more likely to be opioid dependent, especially with this fentanyl crisis in a place like New Orleans, which is a high traffic, high destination kind of place for individuals for parties and events and the like, and get the worst care in the Orleans Parish Jail than you get anywhere else in New Orleans. It was a perfect storm of a bad outcome. In addition to opioid dependency and treatment, the other issue is the consideration of chronic mental illness. And what we tend to do with chronic mental illness is treat persons very often with pills that individuals very often might miss or miss the medication. If you're not domiciled, you have a home, there's no place to put your pill bottle next to your toothbrush, like I do in my high blood pressure medicine, so it's easy to access the next day. So we use shots or injections. They're called LAIs, the long-acting injectables. My good friend, who I think is on today, one of my mentors, Bill Lawson, and I have spoken about that for a decade at the National Medical Association, the value for people with chronic mental illness of the use of injections that'll last up to a month. Medicine like Invega Sustenna, a Risperdal derivative, and in the old days, a medicine called Haldol Decanoate. Much more important for people who have chronic mental illness and who are homeless than other populations because it's hard to access your medicines orally. Neither of those treatments were occurring, opioid management, MAT, or long-acting injectables in the local jail. So I'll stop with that, but I think that you put all of that together, those three issues, there's a lot of meat on the bone, so to speak, and reasons to believe this was a group of persons who are likely had chronic mental illness. Some of them were being mistreated inhumanely, some of them, and had a hard time defending themselves because they were not thinking correctly, all too often due to inferior care. All things that we should try to address in this new jail contract.
Thank you. That's Neighbor Stevens. Any thoughts and questions?
I do have a question. Dr. Bailey, I every day see cases where on the physical health side, a person comes into the hospital with chronic disease and is stabilized, but then when they are stabilized, they are housing insecure and are discharged to the street. I hate to be so blunt, but they're discharged to the street. Now, I am assuming that the same situation occurs when people are discharged from the jail, especially since you have a heterogeneous population of people in jail who are awaiting their trial process and maybe there for a long period of time, or even those who have received their judgment and for whatever reason their time is up and they are ready to be sent out. Now, with your new program particularly, but nationally in general, do you see any move toward more in physical medicine, we call it case management. I'm assuming that you would call it that in behavioral health medicine, so that people, when they are released from jail and may be housing insecure, as well as needing continued treatment, how are you going to be able to facilitate the continuity of care once they're discharged?
Outstanding point, and I'll be brief for this time. I'll simply say that I'll give a lot of credit, I should mention earlier, to us receiving this contract for the new sheriff. Her name is Gwen Hudson. She won the election in October of 21, started I think in early 22. And she's really pushed on the inside and caught a lot of public ridicule as the new sheriff. First time ever an African-American woman has been a sheriff of any county or parish in the history of the state of Louisiana. But she's wanted to make mental health a key theme of improvement at the jail as she became the new sheriff. We've actually already met with her. In fact, we had a meet with her less than a month ago, And exactly the point that Dr. Neighbor Stevens is pointing out was one of her key items, that case management, as you described, I think very articulately, is something she wants to see occur. I think it makes sense. The reality is, if we're going to have individuals in jails or prisons, period, that own persons will be working, putting a lot of effort into providing better overall care, getting them a good evaluation. One of my goals is for every human being who comes to jail to get a psychiatric evaluation. That's going to be a lot. It's a big bite of apple to bite off. But many people in my forensic career, I think I should mention I'm a forensic psychiatrist by training, don't get their first forensic evaluation until after they've actually been charged with a crime or engaged in adverse behavior. I'm sorry, get a psychiatric eval, I apologize. Getting a psychiatric eval might be preemptive, help us determine on every individual who comes to jail what might be a problem that may come down the line. We might be able to provide some care or treatment, medication management, for example, or talk therapy that may be preventative of actions that are not only illegal, potentially violent toward others. We think it'll be a measure of decreasing violence and risk, let alone criminal activity in society. So your point, Dr. Neighbor Stevens, I think is timely and astute. And it's exactly what the sheriff has asked us to do. Let's see how many people we can actually see, get them a good evaluation initially, get them on treatments while they're there that will be paid for by this new contract, and then have case management assess them like if you're leaving a hospital, treat this jail like a hospital because you have many sick people in the jail, and when they get out there, they will remain involved in care. I'll give some very specific examples. One was that they had a contract before that allowed for 30 days of care or treatment after you left jail. That part of a complaint was that the vendor wasn't actually doing that accurately anyway. I have no proof of that, but that's one thing that's been said in some meetings I've attended. But the reality is, the data was showing psychiatry, as Bill Lawson was on, would acknowledge with me, you probably should treat people for a year, not a month, probably 6 months to a year after you got out of a hospital setting, including a jail setting, to give them a chance to kind of get back on their feet, maintain stability and continuity on their medications, get into appropriate outpatient care where they go for at least 4 to 6 visits, not just one visit and you're never seen again, and find some degree of continuity in care. There's a likelihood that if the problem that led to criminal actions or arrest, whether it was criminal or not, or violent or not, was in part due to their mental illness and their impairment in their sequential thinking, maybe we can kind of keep them on track with better thinking due to better care or treatment. Case management, I think you're right, is imperative due to the likelihood that persons will do well, or much more likely to have better outcomes in that regard. We're going to measure this other issue. This sheriff wants us to do what people call research in jails. And I think everybody on your show is aware of how difficult, near impossible that's been able to do in many settings, mainly because of the prohibition against taking advantage of people who are in jail, prison settings. They couldn't give adequate informed consent, but also because very often in many settings, people in leadership, whether it's sheriffs or otherwise, would block it. So having a sheriff that wants to do it, me having an academic-oriented team that needs to do research. I have young people who are looking for projects to be engaged in. It can be a perfect storm that's positive for us to do this thing in a more effective way going forward.
Thank you.
Thank you so much. Dr. Ivan Waltz, sir. Is Dr. Waltz unmuted? Dr. Waltz, are you unmuted?
Not yet.
There we go. I'm unmuted. Dr. Bailey, they tried to silence me, but it didn't work. Dr. Maxey, as is usual, I would be very happy to yield my first question to the amazingly talented Dr. William Lawson, and then I would step in after Dr. Lawson.
Dr. William Lawson.
Yeah, I just want to note that as Dr. Waltz is aware, I used to fairly recently, as a matter of fact, work with the homeless program in DC, which set up a program that tried to provide continuity of care, was pre-incarceration as well as post-incarceration. And basically, there was a mental health system in which we talked to the judges, got a disposition, and the person was then discharged into the community with services. We quickly discovered that there's a whole bunch of barriers, as Dr. Bailey is discovering, that kept folks from having good outcomes. One of them is, of course, that DC at least had an opportunity for folks to go out, and we were able to do a summer program in Austin, Texas. They were able to go out and get jobs. As you know, many people are not particularly interested in hiring people who have a history of mental illness and who are also coming out of incarceration. But nevertheless, we were able to set up jobs with this. Part of the problem is, of course, that we ran into a lot of union resistance, community resistance, because these folks were hired at lower income. Nevertheless, they were able to do this. And once they got in the job, often we need to have someone at the site working to make sure they took their medication and did what they had to do. And then we ran into the problem. I was hoping Dr. Bailey would say some more about this, that they had comorbid abuse, drug abuse within the district. There's very specific rules about if you have a history of drug abuse, the whole issues in terms of being able to get housing, couldn't get it. And if some of you think back, in the old days, we had a gentleman named Ronald Reagan who was disturbed that people who were in jail ended up getting Medicaid. So he led the effort to block having Medicaid available for people who were in incarcerated settings. And so many people, once they were discharged, unless the jurisdiction set up a specific program to pay for services, they weren't able to access Medicaid for months at a time. So they couldn't get, they can't get services, they can't get medication. I also wanted to follow up to a point that Dr. Bailey was made. Our technology is now allowing us to give people long-acting injectable medication. There's 2 studies showing that if you use long-acting injectable medication, you actually reduce the incarceration rate. But they're in the district, they're difficult to get, ostensibly because those medications are more expensive. But if you look at total cost, they actually save money in the long run. And we're finding the same thing with those who are comorbid substance abuse. That we now have long-acting injectables for people who are opioid users. But again, same kinds of issues, cost issues. And this is in Austin and DC, what we call the creme de creme in terms of services that can be made available. These are wealthy cities, fast-growing, got resources. I worked in rural settings. You didn't have this. You did not have this. We would the term we used to call when people turn their sentences up in the rural areas, now you're going to street them, which means, of course, you send them out to the streets, or in the farm area, you send them out to the road, or send them out to the bushes, trees, whatever. There just wasn't any services. Surprise, surprise, they ending up in the correctional system or the mental health system in a revolving door. So everybody recognized the importance of the revolving door. Everybody gives lip service to the fact that post-incarceration support saves money, but unfortunately, the political will is simply not there, especially now, where there's the narrative somehow that mentally ill people are accounting for homicide rates and suicide and everything else.
Thank you so much. Dr. Walks, you had a further question?
I do, Dr. Maxey. It's always good to hear Dr. Lawson talk in depth about how he has been toiling in the vineyard, as we say in church. I want to say something, Dr. Maxey. Dr. Bailey started by talking about how you had been so instrumental to where he and this opportunity is now. I want to highlight a couple of things real quick, and then I do have a question. Dr. Bailey talked about the fact that he got this idea. He and his staff worked to go after this contract, and they didn't get it. And then they worked again, and they didn't get it. And now they've gotten the contract. Dr. Lawson and Dr. Bailey talked about the challenge of this continuity, to Dr. Neighbor's question about this whole issue of, who do you refer them to and what have you. LSU, as Dr. Bailey stated, is already in the community providing services. So I would like to have Dr. Bailey talk a little bit about what with his leadership, what LSU is going to do to provide the continuity of services when folks leave their stint of incarceration and come back into the community. Because it seems to be that that is an answer to and I'm so excited about the potential of that being something that's already built in. I know it is. I've known Dr. Bailey a long time, already built into what he was thinking when they were putting together this contract opportunity. And then while you talk about that, Dr. Bailey, I also want to know how important it was for you to be available to partner with the sheriff and to have that relationship be a part of what you all are doing going forward. So this whole thing about I'm doing this and they're doing that may not be as much of a problem.
So let me add something on your question. That is, are you considering doing anything with the prison or jail staff? Because they're part of the problem as well.
All tremendous points. And thank you guys for teeing it up for me. Several items, I'll try to take them all in turn. Let me first ask Dr. Maxey and your team if our IT specialist can unmute my associate. His name is Mike Okonoko. He's on, great young guy. I want him to be able to make some comments as well. And I want to talk a little bit about a program he has to kind of decrease young Black males going to prison. But he sent me a text and I guess he's not unmuted or whatever. I mean, you can't see him and the like as well. Been working with this guy. He's an ER resident, Dr. Max. He's not a psych resident, but I'm still working on him. But I got his own outstanding program and a guy that I think your group would be very interested in getting to know. Michael Okonkwo. Next, let me ask.
Can I just say to Michael, Dr. Bailey, Michael, they tried to silence me too. Just keep on hitting the mute button and it'll say you can't unmute, but just keep on doing it and then Simon will get you.
And I won't take all the time up because he's an outstanding young guy. I've known this guy a couple of years, Dr. Walks, and he's going to be better than all of us. He's that outstanding. But let me try to take a couple points in turn because you guys are incredible. You're on top of all the key points. The first issue was what are we doing? I thought that David Stevens was timely with the issue about case management. I hope I explained that correctly. And if I didn't say it, I'll put in that we actually have that in the initial grant. The initial grant had 84 FTEs. I think about 12 or 14 of them were for people to involve in case management after somebody gets out of jail or prison. This meeting with the sheriff recently, that's one thing she kept talking about. Bailey, what do you guys have in store? So one of my challenges is to have that in order for June 1st. You're 100% right. Next, I was going to say this a bit tongue-in-cheek, but it really is very true. There are monies for consultation. I would absolutely offer right here publicly to all of you, for Dr. Walks and or Dr. Lawson, if you want to come down to New Orleans for an official consult, I can offer you that because we're all looking for expertise. As Dr. Walks pointed out, Dr. Lawson has tremendous expertise in this area. I've known Lawson for 30 years, as expertise overall, and I am all hands on deck, simply trying to make this thing successful. So that's not an arbitrary offer. I mean that to both of you. We can send you an email. The third thing I'd say is that one thing we have done to try to address success is clinical continuity. So one thing I promised the sheriff I'd do that's been different when entities have taken over the contract newly in the past, I've offered all the people who are there, who are in good standing, of course, to remain on track. In fact, 3 of the MDs who are doing good work, in the sheriff's opinion, actually work for our competitor med school. We had a call as recently as Friday. We got a big meeting March 20th to work out the details where LSU could offer a subcontract to doctors that actually are under contract for Tulane now. And I'm the first to say in this public setting, I've said this a lot privately, I'm new in town. I'm not here for all of the past drama and conflict. I was in Houston where you had UT and Baylor. Lawson's in DC, it Walks as well. I'm sure Georgetown and GW had these little silly spats. I'm not about any of that. We got to get enough doctors quantitatively. We got to get specialists qualitatively, and got to people, I think, whose heart's in the right place in a humane perspective to take care of these 1,200 sick people. 93% are African-American men, if I just said earlier, of the 1,200 people every day in the Orleans Parish Jail. It's incredible. I'd also say that to Dr. Walks's last point, and then I'll stop, this issue regarding what do we have in place, 3 or 4 things. I've really gilded the lily, so to speak, with all of the LSU chairmen for 2 years about this. I kept hoping, and I think Walks read my mind. I love you, Walks, because although I kept being denied I kept hoping I would get it at some point in the future. And I've done a lot. I mean, I've not played fair. I mean, I've been on every radio show. They call WBOK, which is Xavier's radio show. I've said them what I'm saying to you. First, I'm talking about this on your show. I do TV kind of stuff, if you will. And I always mention the fact that I believe one way to decrease violence, they often have me on TV walks talking about violence. There's a violent act, somebody got killed, stick a Mike in Bailey's face. And I always say, it's tragic, it shouldn't have happened. Our heart goes out to you, but there are things we can do about it that I think a lot of politicians don't say. Once we can do about it, it's not the only thing, but one thing that I can do about it is you give us access to the jail. We got 1,200 people under, an institutionalized setting. It functions like a hospital, and we can get the kind of medicines in them. So the people who are doing violence due to paranoia, we might be able to provide some decrease. And Lawson's point that we actually have empirical data showing that you can actually decrease relapse, I think, in violence if you treat people. LAIs is the issue that he and I spoke about, I think, for a decade, Bill Lawson, at the NMA. So this is right in our sweet spot. We've been on this issue for some time. I don't know how many people have had a contract of this magnitude for some time. No political disrespect, but I think in many big cities, state universities have not had these contracts. Right. Private entities have them, and they don't really hire doctors who are at the university. They don't have trainees, no educational piece in play. And I think it just kind of becomes a fight, a free-for-all. I'll share with you, for example, one thing that we're trying to do, to your point, is make sure we're doing teaching and training. I think it was Lawson that made that point. It was our responsibility, because we have both the forensic contract and clinical. So we're going to provide clinical care for these 1,200 people, 500 new evaluations every day, but also all of them have to get a forensic evaluation, competency and pre and post assessment, and then they have to go to court and there's a testify before the jail. I got a whole forensic division that'll be doing that, led by a new Dr. Walsh, who came from Seattle, a psychologist. I think that better evaluations may lead to the kind of recommendations that judges can mandate. You guys know I was at Meharry as chairman for 7 years. I love my Meharry, but one contract we had at Meharry was we had a 36-bed residential treatment facility named after Lord Elam. So people would get sentenced to treatment at Meharry's Mental Health Center by judges in New Orleans through the criminal court if you got a good forensic evaluation. That's not been happening in New Orleans, or there's been no place for them actually to go. We've linked up, I think, with a regional facility so we can, this may go back to neighbor Stevens' comment, get the evaluations and then get judges to sentence somebody to treatment or care, a lot of which is SUD, again, as Bill Lawson mentioned, substance abuse treatment, which I think very often is treatment with fentanyl abuse with naloxone and Suboxone. So a lot of meat on that bone, but I do think that we've started. We definitely have not finished it. I and my group will be very respectful of and responsive to advice, whether you want to send it to me an email or more directly. I think it'd be a national construct. If we can do this well in New Orleans, other cities can do it well also. And in every state of the country, as we've cut funding for state mental hospitals, almost every state of the country has an explosion of mental illness concerns, homelessness, and I think very often violence, mainly against people with mental illness, more so than by them. All issues that I think we in our community have an opportunity to at least try to address at some level.
Thank you. Dr. Hines.
I will go with the stated plan of, did Dr. Okonkwo, was he able to get unmuted? Because I will defer to him if he's ready to go.
Are you able to see him, Simon?
I can see him. He has iPhone there, but he's not unmuted.
Still okay. All right. Well, while we're working on that, thank you, Dr. Bailey. I'm excited about the possibilities that you mentioned.
He's unmuted.
Oh, all right. Go ahead.
Hello, thank you. My name is Michael. Thank you, Black Health Trust, for having me, and thank you for this wonderful conversation. I'm just going to offer a few comments towards the approach LSU is taking in the community to prevent crime from happening. Through the leadership of Dr. Bailey, I, alongside a group of Black male medical students, partnered with the New Orleans Recreation Department this past summer to form a program which targeted violence in the Black adolescent community specifically. Now, data has it here in New Orleans, as in, unfortunately, many urban communities, a rise in adolescent activity and crime. It's certainly prevalent here in the city. And so we wanted to tackle this very specific issue. Now, we use data surrounding coping to guide our method. Now, traditional coping styles, including problems-based coping and emotions-based coping, really forcing the adolescent to build resilience while in the face of an active stressor. Now, although those methods have been successful, given the rise in adolescent crime, something needed to be done. So strength-based coping is an innovative method which actually removes a source of stress and allows an adolescent to build resilience while participating in activities that edify themselves and their own identities. And so we use basketball to implement this, and we operationalize this using the positive youth development model, which stresses 5 core competencies: confidence, character, courage, and a couple of others. And what we did, we gathered maybe a group of 50 young adolescents here in the city, Black males. And each week we brought them into a basketball facility, and we essentially coached that theme using basketball, and we reinforced it during the play. And it received tremendous credit throughout the city. We were part of the local Night Out Against Crime, and we were able to foster a lot of momentum through this effort. And kids provided testimonials in terms of how it helped them face stressors in the social world. So I'm very proud to have played a role in LSU being a face in preventing crime, especially in that high target population. Program continues to go today, and proud to say that Black medical male students have now continued it and will continue to foster this as they go along. And it's been very great here in the city, and we hope it can provide a template for other cities alike.
Thank you, Doctor. Appreciate it. Dr. Jocelyn Hines, Maryland.
Thank you. So Dr. Bailey, when earlier in our talk, you were speaking about just kind of 3 tenets that you plan to bring to the program. You mentioned humane treatment and increasing treatment to access to substance abuse treatment and long-acting treatments. And my first question is around humane treatment. Do you plan to take a systemic approach to educating or enlightening the entirety of your staff? Because as you mentioned, it's everybody from the providers to the nurse techs to the nurses that are involved, who may bring their unconscious bias to what is oftentimes a multi-other population in a jail or prison system, right? Whether it's because of race, because of substance abuse, because of, oh, I think you're violent, because of the mental illness, all of those things. And the other reason I'm super interested in that particular aspect of the question is because you said in the teaching hospital, in the teaching space, you have people who could potentially take that to whatever other institutions they may long-term end up at. So I just wanted to get some insight on that. Again,
Timely. I think you hit 2 or 3 very salient issues, and I'll try to address them. I think that maybe Randall Maxey said as well, but the persons who work there are part of the system, as you described correctly, and the system is broken. Ours, as well as most jail settings around the country. A, they don't feel respected for the work that they do. B, very often they don't feel that it's safe because there's not enough of them, because they're not paid a salary commensurate with what they should receive. The current sheriff is trying to change that, so the persons don't just get the jobs, they do a lot of extra work, those so-called detail jobs to subsidize their work or their salary. They don't get adequate training. I didn't mention earlier, just a lot of meat on his bone, so to speak, but this jail, Dr. Maxey, has been under federal government receivership for 8 years. That's what's surprising to me, how that we got the contract, because last time it came up to get a contract back to the same people who hadn't fixed it before. We've even graphed, I think, how many of the sanctions the federal monitors have made, and I think the highest they got was to 64% corrected. Then it started going down. I think it's back down in about the 40 percentile now. That probably is why they lost the contract, the company out of Tennessee. So the reality is adequate training will go a long way, we hope, toward improving the quality of security supervision and care provided by the individuals who work there. Secondly, we think that giving more responsibility and such and giving more relative importance to them may have them seen more importantly and more saliently, which hope will lead to other kind of advantage, including better salary, which we think matters. These are jobs that should be respected, and people who I think should be recognized and not honored for the service they provide to a community. No community wants a place where individuals have no place to go when they have been arrested or there's been some kind of violent act in play. There's been a lot of bad press. I've been on the ground 2.5 years now. I got to June of 21, and rather than a week go by without there being something on the evening news that's adverse about the overall system. We got to find a way to turn that around because those people who work there see the information, hear, I think, the negative criticism, and that has to kind of carry out into the community. So your point about how we can address managing, I think, the staff goes a long way. That's another responsibility. So again, there's a lot that we have to do. It's not all on our shoulders, but we hope that we can build a team approach. When you heard Dr. Mike Oko make his comments, I think they're very salient. The reality is it should be systemic. It should be a team approach. What happens outside the jail is also important. What happens to young people, like his program that he spoke about, is essential, as well as what happens inside the jail and to people who I think work for the jail, as well as those who are there. Under every rock we look, I think we find problems that need to be addressed. But I think, as I told the sheriff, I think we find problems where there's empirical data arguing what should be best practices. And that's what is my job to do. My title is academic medical director, to bring an academic approach, which is in some regards a different approach than what they've had in the past, and one that the sheriff promises that we can show empirical data for something that they're going to pay for it. And that's what I think the point that I think Ivan Marks made. What does LSU want to do? LSU wants to make sure that we do a good job and that it's at least cost neutral. One thing I want to mention to your group, Dr. Maxey, that's very unique, and one reason I think we got the contract, LSU doesn't make a profit off contracts like this. And that's the issue that I'm not so sure that's true with government everywhere, or is just something that has not really been taken advantage of. But many places that provide care for poor people, whether in jails or not, should look to partner and receive care by state institutions that by contract cannot make a profit. So when we do work for the jail, whatever monies they can provide for us all goes for salary and fringe for my staff. Whereas the company before us was a private company. These private companies, no offense, I know we're on tape here, but they're billion-dollar conglomerates around the country. The joke is how much profit do they take? Is it 10% or 20% or more or the like? So we made this argument to the mayor, who controls the budget, and the sheriff, who controls the care, that every dime that the city pays for this contract will go to the sheriff to manage the aspect of care. Now, Dr. Max, you probably asked me that question, why had somebody been doing that for 50 years? I have no idea, Guy. I don't know if anybody didn't know this, or the case may be, but it's in the charter. A state contractor cannot make profit off of a clinical contract with another state provider. So that's an advantage that I think we bring as a state-funded institution to provide clinical care to these 1,200 individuals. A lot to say, but I hope that kind of addressed your questions.
Dr. Max, could I ask a follow-up question, kind of follow-up, on something that Dr. Bailey was talking about, and also Dr. Michael, something that he was talking about. Now, I understand, you've said it a couple of times, you got a lot of meat on your bone. I'm not trying to build the muscle up on that bone anymore, but you seem to be really good at collaborating and bringing resources together. And I want to think that I'm representing my fellow pediatricians on this call by putting forward the thought that, and building on what Dr. Michael was talking about, this week it was discussed here in Nashville that the state legislature is about to pass, or they may have passed, this bill to mandate gun safety training for kids in school. Now, what I would offer up as an alternative to that approach would be the development of a program, because it's been documented and publicized that the mental health of children has deteriorated over the last 4 years, on top of all the other things that have been going on. I would argue that would not a program in the schools, preferably, that LSU could think about partnering with the pediatrics and adolescent medicine departments and get a program in place in the schools that when children are identified as being at risk or actually in trouble, getting to them at a point to prevent some of the long-term consequences that will inevitably happen if there is no intervention.
Again,
in your head.
No, so again, Dr. Maxson, you just got the best people, the best questions. You guys are ahead of me on all this stuff. And we love us, Dr. Neighbor-Stephens. You're timely. I'd say that I'll say two things. One strategy that we've put in our grant and that the sheriff loves is the idea of specialty clinics. We wrote a document. I can send it to you today. I should have sent it to Maxie last night, where the three we're considering don't exist currently. When they have a clinic, it's just a regular general clinic. But I have specialists in my department. I'll call names. Dr. Creedon is going to give a half day a week as an addiction psychiatrist. Dr. Coleman, who's a child psychiatrist, is going to give a half day a week for MRDD evaluations. And Dr. Simpson is going to give a half day of a week for clinical forensic assessments. I already mentioned that Dr. Hannah Walsh is going to give 20 hours a week doing and she has students under her and trainees, so there's a whole team conducting forensic evaluations. We think the advent of specialty clinics brings a value added, Dr. Neighbor-Stephens. We think it will help offer some utility of expertise that I think has not existed there before. You make the comment in regards to Nashville, this idea that the legislature is going to mandate certain kinds of training. Those are the kind of things that we think germinate out of specialty services and individuals who have spent their whole career. I mean, Coleman is a 30-year psychiatrist like me. Creedon and Simpson are younger and early career, both maybe 10 years out of training. But the reality is I'm hoping that they can identify the kinds of problems that have been manifest, and it's why the issues we have are circumferential and occur in a repetitive type fashion. And while relapse is so common, we also hope that they can make recommendations of things that the city can be mindful of, that we can perhaps ask for funding for kind of going forward. We, like most places, have a revolving door. The data shows that over half the people in jail now will come back to that same jail probably within 24 months. We think there's something we ought to be able to do on the healthcare side to address the healthcare aspect of the problems that many of these individuals actually have kind of going forward, rather than only trying to treat what may in some cases, not all, but some cases, be healthcare problems that we're trying to treat with, I think, legal solutions or, heavy-handed, punitive type solutions. If I can go back to Dr. Michael Oko, because that's one thing that I'd love for him to talk about, what they're doing with the young men to address, I think, the different strategies that we're trying to early on engage young men on so they can have some conflict resolution training or exposure before they finish. This is a high school type program. Can I go back to Dr. Oko?
Yes. To address that prompt, I would like to, mention a different actual program that's ran, one that actually ran through a barbershop in New Orleans, in which we enforced the idea of ethnic identity into the psychological structure of Black males, with the actual intent to, again, build resilience, with a hypothesis that due to racial socialization, Black males in particular do not have access to an identity frame that allows them to be resilient to a lot of these impulsive-based outcomes. So with that particular program, what we do is we expose young Black males to actual teaching material that informs them about the history of slavery in America, and actually the history of those who were actually enslaved in their communities, and how they were functional and how they had capacity in their communities before they were enslaved into America. And we tried to enforce that sense of identity, that sense of capacity within them. And I find that particular program to be uniquely impactful and allowing young Black males to kind of have a sense of self that can allow them to have the sense of esteem that can allow them to be functional in society, and less impulsive to, different stimuli that can, unfortunately lead to outcomes that, resort to a jail, etc.
Well, thank you so much. This has been a wonderful program, Dr. Bailey. I want to just address one more time before we see if we have anything in the chat. Is there any use or value in you having a program that is facing the actual staff of the prison, meaning the guards and the way they treat patients? Won't that stop some of the in and out problems that we have? And if my co-moderators will see if we have any audience questions or comments. Dr. Bailey.
Well, I'll be brief. I'll just say absolutely. As you mentioned that earlier, I was saying that one of our one thing we actually put into our initial proposal, that again I mentioned we wrote in 21, we failed, we tweaked it in 22, we failed, and I think essentially the same proposal was accepted this time. I think the sheriff leaned in and said, "Well, this is what we really need, much more of a healthcare approach and the like." It absolutely includes, I think, training for the jail staff. I was making a point earlier. Part of that training has to be that persons are treated like professionals, rather than they wait until there's a mistake made and then punitively the city comes down on them. There's discussions about criminal charges against people in a setting when they fight. There's fights regularly in jail settings. Hard to work there if you might be criminally charged if they're fighting and somebody's views differently what you did trying to stop it. Now, you do need to help them also have, as you described, what I call conflict resolution strategy. That's why I want to go to Mike Oko. Some of that, I think his group is teaching before people actually go to jail. But some of that you're teaching the people who are going to work in the jail as well as those who are going to be there. Remember, most of the people from jails, unfortunately, very often come from the same communities and they know people. So people who work in a jail very often are different subculturally from folks who are policemen on the streets. All too often on the outside, my experience has been, and it's the same in New Orleans, where the policemen on the streets don't really know the individual. That's why some cities require that you actually live in the same community. I know Memphis, Tennessee had a big lawsuit about this because the policeman lives in one place and didn't really know the communities they actually patrolled. Jails are very different places subculturally, and very often Joe Smith, who works in a jail, went to high school with Peter Jones, who's in jail on a Friday night. That can be positive or it can be negative, based on how that individual is trained to manage and because you really are managing people that you're responsible for and you're over, because you have some authority when you're the jail tenant or the correctional officer. So you're 100% right, Dr. Maxine. That's the issue that I need to be on top of my game about. I'm going to make sure that I've done some of this. You guys know I actually worked in a prison in Connecticut, the Garner Correctional Institute, some years ago when I was in fellowship. But most of my career, I've actually gone in and out of jails to do evaluations. Done a lot of reading about it academically and esoterically, but I'm not somebody that's worked in a jail full time for 30 years. So I've got to kind of get on top of my game as well. And I think your point and your question is timely. We must make sure we give adequate and optimal attention and training and professionalism to the staff to address, I think, many of these long-term systemic problems in jails and prisons.
Well, thank you very much. Dr.
Can I
Stevens,
ask one more question, Dr. Bailey? One of the things that this conversation we haven't really touched on too much is because many of us probably have friends or loved ones, family members that might have chronic mental illness that are in jail or prison systems. Are there some things that you could recommend to our audience in general on ways that we could advocate for them, or things that we can ask for? Do they have any rights, so to speak, to mental health evaluations or anything of that nature?
Absolutely, we're well-intentioned. There's a lot that I think we all on the outside can do and should do. I think the first issue, to be blunt, is politics. We need politicians that see people in jails as humane. So I think that language matters. We spend time when we do radio shows here trying to change the language from prisoners. You're not a prisoner if you go to jail. You can be pre-adjudicated. My name is Ron Bailey. I'm sitting in my house right now. For any number, my neighbor could call right now and say, I sexually abused my child. The cops will come and arrest me and take me to jail. And I've never sexually abused my child in my life. Until I can get a lawyer and defend myself and go through the whole process, I'm in jail. I'm not a prisoner. I'm pre-adjudication. That's a huge issue, understanding the difference to people who are in a jail, pre-adjudication, before the arrest. Even if you're arrested and found guilty of a crime, if you're going to be in jail less than a year, for a non-violent crime, a misdemeanor, you may still stay in a jail. The people in a jail are very different than people in a prison, and language matters. A. I think B, people need support. I think it's surprising how often individuals just simply don't have any information, education about the process, or resources. I think I even alluded to it earlier. Many people plead guilty. They take a plea bargain because they think it's better to just plead guilty and get 6 months or 9 months or 2 years in jail. Then let's just face it. Often prosecutors throw that they have all of the power. They throw the book at you and say, if you go to trial and we get a guilty on you, we'll give you 40 years for whatever the alleged offense really was. In my life, I don't want to go to jail, but I might take 2 years rather than risk getting 40 years at age 58 if somebody charged me something that I know I didn't do, but I don't really have the resources to hire the richest lawyer in town to give myself an adequate, let alone an optimal defense. That's an unfortunate reality of the American criminal justice system here in New Orleans and everywhere in the country. Third, I'd also argue that people need support there. I simply encourage people to go and visit your relative, to ask questions. It's interesting to be a healthcare provider in a jail where you get a letter from a family saying, is my brother Joe on his high blood pressure medication? I mean, one of the big challenges that the sheriff asked me of me 2 years ago when we wrote this grant was, can you get people seen within 24 hours? And I mean, we wouldn't imagine. I mean, I run a department now. We got a big emergency room. People don't go to the emergency room and just sit there for 3 days before you see them and get them right back on their high blood pressure medicine. They don't get right back on their schizophrenia medicine or depression medicine. I think we should be able to see every human being who shows up in jail within 24 hours, one way or the other. But on some nights, they'll arrest 100 people in New Orleans, and they all show up in jail, many of whom are already on medicine. They're just trying to ask somebody to get back on their medicine. One thing we have to also do is make sure that we coordinate the electronic medical record system. This company, I think, has the same EMR that many correctional systems do. I think it's called CORE, and we've got to find ways to make it talk to. We have the big company, your Epic. So if you're an individual in town, whether you go to the hospital and they have Epic, or whether you go to one of your clinics that have Epic, if you go to jail, since you can't have Epic in the jail, they've got to pay to make sure that CORE talks to Epic. Otherwise, Joe Smith comes in on a Friday night, and no doctor can find out if he's not talking to them correctly what medicine they're on. And some people go 3 days without medication until Monday, and all blank breaks loose, and then you're violent. And if you're violent or agitated, other kind of bad things may happen to you. There's a lot more I can say, but I hope that those are 3 or 4 very tangible examples of things that I think we can do, and very often families can help us engage in. Simply calling and tell us what medicine the guy's on could go a long way.
Thank you so much. Before we close, are there any audience questions, Dr. Barbara Neighbor-Stephens?
No, I don't see any questions. I do see that Dr. Lawson has his hand up, but there are no comments.
For a brief comment before we go to final comment, Dr. Lawson.
I'll be quick. That's one of the points that Dr. Neighbor-Stephens made. Really important issue is problem of early recognition, and this is a very controversial issue because on one hand, you want to get early recognition and treatment of folks, but on the other hand, it can be used as a tremendous source of abuse to folks in our community. And I've seen there have been various initiatives that they've all fallen apart because of the fact that you may be arresting or stigmatizing someone before they've actually committed a crime or done anything. And then the second point that Dr. Daly did, excellent point, is what do you have in terms of family members? And I had a family member who went out and killed his wife and his kids. Everybody went into hiding when he was released because, frankly, the forensic facility was overcrowded. So it raises other issues about what do you do if you have someone with a history of violence, and how could family members get support? I've been working with the National Alliance for the Mentally Ill, who've been very aggressive in terms of these kinds of issues, and I suggest to give them feedback as well as the Depression and Bipolar Support Alliance, who are well aware in terms of the concerns of family members about these important issues.
Thank you so much. As we go, we're past the top of the hour. Dr. Michael Okonkwo and Dr. Bailey, you have final comments before we go to our moderators?
I'll let Mike go first.
Yes. Yeah, I certainly think the importance of, adolescent adjustment is a topic that, should continually be considered, studied, and refined as we try to address issues that lead them to these unfortunate outcomes that young Black Americans face.
Thank you so much, Dr. Bailey.
Yeah, first of all, thank you guys for having me, Dr. Maxey. As Ivan Walks mentioned, I talked about you a lot, and I'm not just blowing steam up your socks. Maxey really did tell me about this, and he deserves a lot of credit for it, and I mean it. Secondly, thanks for letting me have my young guy on. I'm telling you guys, this guy is outstanding. He's got ER training with psychiatric underpinnings. I think we may have him on again at some point if we can, Dr. Maxey, about his program, because I'm very, very encouraged by it. We published 2 papers together in my 2 years here. So I think Dr. Oko is outstanding in every way. I think by saying I thank you for Black Health Trust. I think it's an educational value to our community. Gives a chance to kind of discuss these kind of issues. This probably has been my best example with the hour you've given me to go through all of the stuff that's important. And you've asked the right questions. So I almost wish hope we've taped that I could write this up. Oko writes a lot of things up for me. We've really never had the venue like this to put all of this in writing. And I got a sheriff now. If we do so, I think she'll make sure it comes to the light of day, because there's just so many issues. Jails, unfortunately, represent such the lifeblood of many poor people in urban areas. A lack of factories and lack of economic opportunities and lack of jobs and education. Not everybody, and we're not blaming anything for what people do, but certainly it's a system that if not encourages, allows, or does not discourage behaviors, they end up having people in jails or prisons. And then so many of the other so-called social determinants of health come out. They're not educated, and they're not employed, and they have no money, and they have no support, and they have food deserts and all kinds of things. It's a big piece of the apple to bite off, but I think that we can do a lot to help communities that suffer by providing optimal healthcare here, and then really working to move the needle to a better overall treatment of individuals from communities in poverty and with many functional deficits. So thank you guys for the opportunity to discuss this today. Also thank Dr. Lawson for his outstanding comments.
Thank you so much. And let me know if you need a psychiatrically trained nephrologist to come down there. Dr.
Absolutely.
Final comment.
Who did you call on?
Dr. Hines.
So thank you very much, Dr. Bailey and Dr. Mike. This was a very informative discussion, and I am congratulations on your tenacity and the way that you've continued to pursue this endeavor. And I'm excited for the ways that, as you mentioned, and then I'm going to go ahead and claim for you that you will be an example to other big cities and for other partnerships in creating a more robust and comprehensive system for those that find themselves in jails and prisons. So thank you.
Thanks.
Dr. Ivan.
You know, Dr. Maxey, I'm sitting here smiling because I've known Dr. Bailey a long time, and I've watched him have an impact and have an impact and have an impact. One quick recommendation: when I've done correctional psychiatry, I found that if allowed, it's really useful to attend the morning roll call that the correctional officers do, so you can listen to what the challenges are in a particular part of the jail or prison system, and maybe be able to understand the mood of the correctional officers and what's going on in their work environment, because it ultimately is the work environment of the mental health professional. So hopefully you all will have the opportunity to do that. My closing comment is this: what Dr. Bailey is describing is how, if given the opportunity to, the way it is in my mind, and Dr. Bailey knows that my mind doesn't work like it's supposed to, I see him as the conductor of an orchestra. I see him as being able to think comprehensively about what the music should sound like, and be able to point to the violins and the cellos and the drums and all of that, because someone has to be willing to stand up there and do that. The opportunity to do that may not be apparent when you start, when you're a resident, when you're a medical student, or you're a resident in the ER, or a resident in psychiatry. It may not seem like you can be someone that's working with the government officials, working with the sheriff, working with other folks to make something happen that makes sense for the community. But none of us can really impact the community by ourselves. It just, the community doesn't work that way. So I'm always excited to have Dr. Bailey come and share what his next vision is and how he's even more opportunistic in a positive way and comprehensive in a visionary way, and how that is, in God we trust, all others bring data. The thing about people like Dr. Lawson and Dr. Bailey is that at the end of all of this, we're going to have something published. We're going to have some data about what they did and the extent to which it worked. And that's how we make progress. Not that, you know, I look really nice and I wave my hands well, but we have evidence that we did something that mattered. So God bless you guys. Just really thank you and just really appreciate what you're doing.
Dr. Walsh, I like that orchestral reference you made to Dr. Bailey. That's really good. Dr. Barber.
Well, Dr. Bailey, I want to thank you for again joining us and bringing us a report on the work that you are doing. What comes to my mind as we come to the close of this program, and I have said it in different ways at other times, we can't wait for somebody else to help us get out of the mess we're in. We need to use all of our skills, all of our talents together to help right the many wrongs that exist and that are suppressing our community. And so thank you for what you're doing. You are an example of how we actually can make a difference.
Well, thank you so much.
Thank you, my friend.
Thanks again, Dr. Michael Okonkwo and Dr. Bailey for being here with this wonderful discussion. And thank the co-moderators. And hopefully next week we're going to be joined by one of Dr. Stevens' co-pediatricians to speak about immunization, how that fits into politics. We're waiting on a confirmation of that. And we'll be based back again in the state of Tennessee. Everybody have a great, great Sunday. Have a great day. Goodbye, everybody. And thank you, Simon.
Thank you now.
Bye, everyone.